Good to have you joining us. My name is Anissa Mitchell with PMD Alliance, and today we're going to be discussing anticipating needs through the Parkinson's journey and what that means. This is actually information from a research perspective on what it means to be proactive and like planning ahead for things in regards to disease progression. We talk about this at PMD Alliance a lot, the importance of thinking about things that are important to you and what things might look like for you later down the road and how you want to manage that and some options that you have. But I don't think we've ever done anything from this approach today, where we have it from the research perspective, both from those in the community as well as movement disorder specialists and healthcare providers. So I'm excited to have this conversation. Of course, as usual, I want to invite you to ask questions and make comments throughout the day, so that at the end or out throughout the time that we're having today, that we can address those questions at the end. And with us today is a movement disorder specialist, Dr. Jennifer Corcoran. She is a fellowship trained movement disorder specialist, and she's an assistant professor of neurology at the University of Rochester Medical Center in the Neuropalliative Care Clinic at Rochester, New York. So I'm excited to have her joining us today, and I'm going to pass this over to you, Dr. Corcoran, and let you get us started.
Hey. Well, thank you so much for having me. Can everyone see my slides okay? Looks okay. All right, great. Well, thanks so much for letting me join your webinar, and good afternoon, or it's afternoon where I am right now. So, like Anissa said, I'm Jen Corcoran. I'm a movement disorders neurologist with a palliative focus at the University of Rochester in upstate New York. And today I'm going to be talking about some preliminary results from a recent research study of mine on what I'm calling anticipatory guidance in Parkinson's disease. This study was funded by a university clinical and translational sciences institute pilot grants. That's my funding source. And I've also received some funding support from the NIH and the American Academy of Neurology for other projects, no other major disclosures. So I know this is the PMD Alliance and this audience is probably familiar, but just to state the obvious, Parkinson's disease, or I'll be abbreviating it PD throughout the talk today, is a chronic, a slowly progressive neurologic disorder that over time causes like a chronic and slow accumulation of motor and non-motor symptoms over time as disease progresses. And that in practice means that people with PD, or PWP is what I will use, is the abbreviation I will use in this talk, that people with PD and their care partners have to experience and deal with, and maybe ideally plan for, this long period of increasing care needs sort of as the illness goes on. And it might seem intuitively obvious that counseling about anticipated disease progression and planning for the future would be a key component of patient-centered care in PD, but there's prior literature that shows that actually a majority of people with PD and their care partners have reported that their neurologists discuss this topic never, rarely, or only if like the patient or care partner raised the question first. And so that was a survey actually some colleagues of mine did, where the number of people with Parkinson's and the number of care partners who said that they discuss the future rarely, never, or only if their neurologist brought it up first was like in the 80%, like around 84%, something like that. And that survey was actually done, I note, in Parkinson's Foundation centers of excellence. So not everybody gets care in a center of excellence. I would like maybe guess that actually the rates of non-discussion of the future is maybe higher than the 80s then in like private practices or other settings. I don't know that. I'm not aware of any research about that, but I would guess. So even in theoretically the best centers of care, like no one, it seems like, is talking about this. And, I remember reading when I was doing some literature review on this topic and planning this project and applying for funding, a really poignant quote from a paper that one of my mentors had published from his time at a different university, where there was a care partner of a person with Parkinson's interviewed. And there was this just really poignant quote where she said, something to the effect of, when I ask about what to expect in the future while caring for, I think it was her husband, about how do I plan for the future, I just get told, well, everyone's different. And like maybe that's true, but that doesn't help me think about like, will he need a nursing home someday? And if so, like when will that happen? How will I know? And I think in practice, when I was in training, I would hear like the people training me say that a lot to people who are asking. Well, everyone's different. Like, okay, that's true. Everyone's Parkinson's disease is technically different. However, that is kind of like a useless statement for people, realistically, I think. It doesn't really tell you much or how to plan. And that's sort of how I got into my interest in this topic, which is anticipatory guidance, which I'm defining here as the practice of proactive counseling about future disease progression and how do we plan ahead. That might include, medical planning, like having a healthcare proxy, doing medical advanced care planning, like medical advanced directives. But broadly, that could also include things like, you know, planning for increased care needs. Like, when does one think about like assisted living or more help in the home, like any legal or financial planning. Like I get a lot of questions in practice, like should I move to be closer to my children? So definitely in practice, people are asking me these questions. And this all got me really interested in the topic. So I knew that there were unmet needs both from clinical experience and from this prior literature. But there really was not a lot about like what are the specific needs that people with Parkinson's and care partners are experiencing. Like, are there common bumps in the road that people wish in retrospect that they knew were coming? And actually really like nothing out there that I could find about neurologists' views on this. Like, what do they think they're doing? What do they wish they were doing? What training have they had? What are the barriers? And so I felt like there was just a lot missing that I needed to figure out before I could go ahead and, in the long term, think about like an intervention to improve the state of anticipatory guidance and make it more of a cornerstone of care for PD. So that's sort of the background. And so, I was initially thinking about things like surveys, but then I felt I don't even know what questions would I put on the survey? Like, what is even important to people? So, to start getting at the problem, I used a study design called a qualitative descriptive study. So, qualitative meaning not worried about numbers or measurements. I was just talking to people and like asking them about their experiences and what was important to them. And descriptive meaning I didn't deliver any interventions in this study. So today in this talk, like I'll be talking about research results. The views you'll hear are a lot of from the study participants, people who signed up kindly and gave me some of their time and interviewed with me. I didn't invent or deliver an intervention here, and I'm not here to say give you advice about planning for the future, just to be transparent about that. So I did semi-structured interviews with just different people who'd hopefully have some kind of a view to share with me. And I talked to 17 people with Parkinson's, 14 care partners of people with Parkinson's, and 11 neurologists who take care of people with Parkinson's. And for qualitative studies like this, like these are typically small sample sizes, like you see here, because we're not looking for like a big representative slice of the general population. I was really looking to go in depth and really explore the topic with people from different backgrounds. So I used an approach to recruitment where I was like very intentionally trying to find people with different disease experiences. So tried to find people across the disease spectrum from relative. I had a few people who were relatively newly diagnosed. I think the most recent was like within the last year of the interview with her. And then there were people who were fairly advanced, people who'd had deep brain stimulation. I talked to some people who are just starting like the subcutaneous therapy, like subcutaneous foscarbidopa, foslevodopa, people with young onset Parkinson's. Even my colleagues were kind and helped me find people who'd had issues like, cognitive impairment or orthostatic hypotension, like some of these other complications we think of with Parkinson's disease. And same thing with the care partners. I tried to find, care partners for people with cognitive impairment and, people who'd had deep brain stimulation, etc. And I also included in there, talked to a few bereaved care partners as sort of a unique eyewitness, in my view, to the very last bits of Parkinson's disease to hear from them, like what may have been surprising, what do they wish they'd been prepared for. And then, very similarly with the neurologist, I tried my best, and I'll tell you how well I did later, to find people like across the career spectrum, like people in early career, just out of training, people in later career, closer to retirement. It was also my aspiration to find people in academic practice, like people who are in a center of excellence for Parkinson's, but also people in non-academic practice or private practice, which was fairly challenging. And I'll tell you later how I did. So trying to get like a diversity of experiences, not necessarily like the most representative slice of the population here. Interviews were all recorded and transcribed verbatim, which helps me analyze them later. And analysis is currently ongoing, but some themes are emerging from our analysis, and that's what I'll share with you today. Some preliminary themes that are coming out. Just so you know, or to give you an idea of what's in these interviews, they can be a little freewheeling. It's called a semi-structured interview for a good reason, that we can really explore something. And to be honest, like sometimes I would always start by asking, like, can you tell me a little bit about your Parkinson's journey? Or for the care partners, can you tell me about, your and, your loved one's experience with Parkinson's, and like, how's it been for you as a care partner, right? Least as much of a synopsis as you can give me, like what have been big struggles, bumps in the road, to sort of help like frame for me, how the interview might go, what things I might want to ask about specifically. And so here are some sample questions from the patient and care partner interview guide. Just, do you feel that you have adequate information about what to expect in the future, with Parkinson's? And if not, who do you wish gave you that information? If you have a neurologist, or if your loved one has a neurologist for the care partners, and everyone did in this study, have you ever talked with them about how life might change in the future because of PD? And if yes, please tell me about this conversation. Like, how did this start? Who brought it up? How do you think it went? Was it helpful? What about it was good? What about it could have been improved? If no, do you wish you had, or would you be interested in doing so in the future? And if you would like it to do so in the future, who should bring that up? When do you think that should happen? Should that be something your doctor is proactive about, or do you feel like it's something you should be starting? Questions like that. And what aspects of PD related changes over time do you think neurologists should talk to patients and care partners about before they happen? So just trying to like get at this question with a bunch of different approaches. And then here are some sample questions for the neurologist. So I would also start these with, tell me about your practice and your experience treating people with Parkinson's disease. So many of them were movement disorder specialists. Some of them split their time between research and clinic. Some people almost like their entire practice is Parkinson's. For some people, there's more of a mix. And, there was one general neurologist who we even talked about, like, what is your threshold to refer people to movement disorders? Because I wanted to get a sense of like, where in the disease trajectory is she seeing people? Like, is it mostly early? Is it all across the board? And so for neurologists, I would ask questions like, what is your general practice with regards to talking with patients and care partners about what to expect over time with PD? And people would sometimes bring up like specific examples, like this one time, or remember this one very memorable patient and family from their clinic. And we could ask, like, how did you decide to broach this topic? How do you think that went? Or if you decided ever to like not talk about this for some reason, like, how did you make that decision? How did you feel about it? Are there aspects of PD that you think patients and care partners are often surprised by or unprepared for? And in your opinion, what are the barriers to counseling patients and care partners about what the future will look like with PD and how to prepare for it? And then I also had questions about like, what kind of training did you have for this? What kind of training would you like to see in the future? Things like that. So who enrolled? I made my efforts to recruit as diverse a group as I could. Doesn't always work out like you want it to. So the people with Parkinson's had an average age of 70.8 years. The care partners on average a little younger. They had an average age of 66.7 years, probably because there were a few children of people with Parkinson's who were care partners here who were younger, on the younger side. The people with Parkinson's had an average time since diagnosis of 7.8 years. I did do this, I got the year of diagnosis either from the chart if they were cared for in my own center, or if they were cared for in another center. When did they report being diagnosed? And I will note it was, because it sometimes comes up, it was time from diagnosis, not time from symptom onset, which, frequently is like a few years before diagnosis. For the care partners, I asked, how long has it been since you've been in a care partner role, which there was an average of 4.4 years here. And, interestingly, some people said it was like right from the time that my loved one was diagnosed with PD. Like I started going to appointments, getting much more involved. I feel like I've been a care partner since then. For some people, it's like there was some milestone in PD, or just slowly a few years in, they started taking on more of a care partner role. There were, I think, maybe two people where the care partner role kind of predated the PD just because there was some other big medical issue. One person had had a significant cancer before having PD. There was someone else where their wife had had a lot of surgeries, again, a few years before the PD. So there were a few people here where their time spent caregiving was longer than their loved one's diagnosis of PD. And this is another one where I sort of let the participant in the research kind of self-report, like, what is caregiving to you? Like, when do you feel like you became a care partner? I'm sure we could all differ. We might differ with them depending on who you ask, but that is a self-report. The people with Parkinson's were majority male, 64.7%. The care partners were predominantly female, 78.6%. And that's pretty common actually in literature on care partner well-being or caregiving experiences. That's pretty common that most of the caregivers enrolled in research are women. So this is in line with other caregiving related research. The people with Parkinson's were 100% white. My care partners were 92.9% white. There was one black care partner who enrolled. And of the care partners, 71.4% of them were the spouse of a person with Parkinson's. There were a few adult children. There was one sibling who was a care partner for a person with Parkinson's. So with qualitative research, we sort of analyze these transcripts, we go through and identify themes that are emerging. And so I'll go through a few themes from the person with Parkinson and care partner analysis that we've been doing with some representative quotes. So these are not finished, these could be these could be different by the time we get to publication, but I did all the interviews also, so I think I had a sense early of what was kind of coming out. And all these names, by the way, are pseudonyms. Everything has been identified or been de-identified. So the first theme I think that is a really big one to highlight is that people with Parkinson's and their care partners do not routinely discuss future disease progression with their neurologists. Like that was very clear. Many people sort of mentioned that they're just not talking about this in their care. Margaret is a person with Parkinson's disease who said, I guess I've never really talked about that with my doctor as far as what can I expect in 5 years or 10 years, or what should I plan for? And Betty, a care partner, said that would have been nice, but no one did, which I think is like a very like straightforward way of saying like she would have appreciated it, but it never has really happened. But theme 2, people with Parkinson's and their care partners desire actionable information about future disease and symptom progression, or at least the majority seem to. So Jennifer was a person with Parkinson's who, I remember her interview pretty vividly. She'd been diagnosed within the past year, very new to this, still working, pretty active, and said, and I've been to Russia and Estonia and lots of places, and I enjoy that. Am I going to be able to continue to do that? Am I going to be able to continue to teach at a national level in her professional organization, which I took out here for anonymity purposes? How much longer can I do that? And for her, these were like very concrete questions. These were not just musings. Like she had lists of these questions that she had already been planning to bring to her next neurologist visit, partly for bucket list purposes. Like she was born in another country. She was sharing with me just beyond this quote, she wants to bring her granddaughters back to visit that country. And she wants to know, like, what time frame should she be thinking of to be most likely to be able to do that? So she was someone thinking like really concretely about these things that are important to her that I suspect don't come up in clinic visits very often unless we're asking or someone brings it up. And then Karen, a care partner, just said, I think at each of the stages, as the doctor sees that there's changes and these changes are going along the line of more of the disease process, they need to talk about it and say, hey. So sort of feeling like, the neurologist should be responsible for if they are identifying that things are progressing or we're in a new phase of disease, like we should be talking about like, where are we along the roadmap of disease progression here? So I don't know. I think those things are just like, that's maybe one of the biggest findings for me is that like people are not talking to their doctors about it, but they want to, or they at least want actionable information about the future. Then theme 3, people with Parkinson's and care partner preferences for timing and content of anticipatory guidance vary. That's probably might sound intuitively obvious, like we're all individuals, we all have our preferences for how we communicate and what we hear. But I think it is really important context, just for thinking about how to improve this situation in the future. So Matthew, one person with Parkinson's, said, when, I would often ask, like, all right, everyone's got a different opinion about the right time. What's your opinion of the right time? And Matthew said, very early, to allow as much time as possible to put things in place and consider things appropriately. And that was actually a surprisingly common viewpoint. Plenty of people said, like, day one when I'm diagnosed, or like in the first year, I really want to start hearing the nitty gritty about what how I can expect life to evolve as disease progresses over time. I think maybe like I was surprised by how common that viewpoint was, though not universal. And plenty of people kind of said, like, even the stuff that might scare me or might be hard to hear, like, I really want to start thinking about this early. And then Elizabeth, a care partner, a little bit of a different view, said, I think the right time is when the motor skills start to decline. When you can't do things for yourself, that's the time to start that discussion. And some people did identify like a disease milestone, or like a certain like complication maybe, where it would really be time at that point later in disease to start talking about where are we, how might things go in the future. So different preferences. And then last theme for the patients and the care partners. Patients and care partners seek information from support groups, online resources, and their families and social circles. I heard a lot about various like online websites for the different, there's a few Parkinson's disease focused foundations out there. People were looking. Support groups are a really common one, just where a support group, a lot of people cited support groups as a place where they're meeting different people with Parkinson's, they're seeing kind of the spectrum of disease experiences people may have. And especially for the people earlier in disease, they're meeting people further along the journey who are having different experiences. And several people reflected to me that sort of seeing their co support group members deal with different things was giving them a sense of what they might need to think about for the future, like housing considerations, things like that, planning for increased care needs, etc. And then the families and social circles. I mean, Parkinson's disease is common enough in the general population that there were a handful of people who had had another experience of Parkinson's disease in the family. So, for example, one emotionally pretty tough interview was with the husband of a woman with Parkinson's disease, who with pretty advanced disease, who was sharing his experience that like her mom had had Parkinson's. And so it's not his first time going through the journey of Parkinson's with somebody in the family. And same thing with social circles. Like if people live in like a senior community or something like that, sometimes people just like happen to know in their social circle someone else with Parkinson's, and like people were taking note and seeing what they were dealing with. So a good example, like Richard, a person with Parkinson, said, I've observed what my peers in the boxing class have dealt with, because Rock City boxing and pickleball are very popular activities in the Parkinson's community in Rochester, and the various combinations of symptoms that they have. Everybody has something in common, but not all the same and to varying degrees, which I think is very true. He's accurately identifying the heterogeneity of the Parkinson's disease experience and really learning from that. And Sandra, a care partner, said, I am inundated with information, do a lot of reading. We are very blessed to have this new network in our city because we're getting a lot of good information from their programming. I took the name out for anonymity, but it is a network in Rochester, New York, that does, it's not really a support group, but it does do a lot of like educational programming. They have a lot of speakers on a million different topics, including one recently I got an email about for like legal and financial planning topics. So they are kind of touching on some future planning issues in their programming. And so I don't know, I thought this was really interesting that people were like not talking about the future with their neurologist for various reasons, but also like really actively seeking information elsewhere, including from people who sort of self-identified as not much of future planning people. The first gentleman I interviewed for this study, I asked him, like, are you a future planner type person or no? And he said, no, I live in the moment. And I thought, oh, okay, well, this might be a tough first interview for the study, but here we go. And he has like a million plans for the future, like very realistic about things. It was very surprising to me sometimes, like how many steps people have taken to prepare for the future when they weren't really a future planner person by their own admission. They sort of seemed like planners to me, but they get to describe themselves. And so those are the sort of key findings thus far from the patient and the care partner interviews. And then there were the neurologists. So the neurologists had an average age of 42.4 years, which for context is on the relatively young side of the career spectrum, just because of it, most of us enter practice in like our 30s because training takes a long time. And they had an average number of years in practice of 10.2 years. This was probably a little bit skewed by just a few people in later career, but I would say in general, it was a relatively early career neurology group. They were predominantly female, 81.8% females. That was just 2 men in the sample. Majority white at 63.6%, 27.3% Asian, and 9.1% Black. 81.2 of them were movement disorder specialists. One was a general neurologist, and there was one person who, interestingly, was practicing as an attending and seeing Parkinson's patients in a telehealth practice, but was currently in a fellowship for more cognitive neurology. So, sort of had an interesting perspective, because in cognitive neurology, where she had a lot of focus on cognitive and psychiatric complications, she was seeing a lot of people with like more advanced stages of Parkinson's. The majority were movement disorder specialists. Oh, sorry, I mentioned that. And then the vast majority were in academic practice, which I think will influence some of the findings that we will go through. So despite my best efforts, I did wind up recruiting a predominantly early career sample of neurologists. So I'll go through 4 themes that are emerging from the neurologist interviews as well. First is that anticipatory guidance is woven into discussion of new PD diagnoses. So I asked everybody about their general approach to talking about future disease progression with their patients. And basically everyone referred to the discussion that they would have with people at the time of a new PD diagnosis. So again, these are all pseudonyms and these are all neurologists. Amanda said, when I make the diagnosis, I give them a broad brush overview of general prognostic information about Parkinson's disease, progression, etc., because I've had too many instances of people coming back and it's almost like they didn't expect it to get worse. So I would say basically everyone who I interviewed talked about like sort of the discussion they have when someone has been newly diagnosed, or maybe in like the first follow-up visit or 2, acknowledging that sometimes in the first diagnosis visit, people sometimes feel like a bomb got dropped. It's really not the right time to always give like a really big, long-winded explanation, or at least that was some people's view. And I'd say that was the most universal topic that came up. Practices about what happens later in disease, like when do you revisit the topic, that was much more variable. Theme 2, there are multiple barriers to routine anticipatory guidance in PD. So Stephen was one more late career neurologist, said, I think a lot of times patients may wish to speak about the future, have curiosity about it, but clinicians sort of dread the conversation. And brought up sometimes, I heard this from a lot of people, that sometimes from the physician side, people are worried about upsetting people, worried that this will be emotionally tough, worry about navigating, like if a person with Parkinson's and a care partner have different views on what do we want to hear and when do we want to hear it, that can be challenging to navigate. And I will say this neurologist is in later career, has had patients he's followed for many, 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 many years, and was actually very self-reflective about the way his own life sort of intertwines with his practice, and how sometimes it might be hard for him as now an older gentleman who's been aging alongside some of his patients for the last few decades, that sometimes his own like emotional barrier, like he's attached to patients, he's aware that he's aging, may impact like his willingness to have these conversations. And Ashley, I think, actually like names a really common theme that came up, which said, I'd say time, with clinic work, we're only allotted a certain amount of times. And so I oftentimes will find 30 minutes is just not enough time with our PD patients, especially if they're really struggling. But I feel like there's always an obligation from our medical system to see more and more patients over time, and you don't really spend the quality time with people. And I think basically everyone brought up time as a limiter. People brought up the idea that, when appointments are 4 to 6 months apart and people have a lot of medical needs, when they're seeing a patient, that they feel like they're doing so much catch up, like so much trying to catch up from like what all the issues have been in the last 4 to 6 months since a visit, that they're not having time to sort of like step back and talk about the big picture and like where are we along the journey or the roadmap here, and like how do we plan ahead. That there's a lot of like putting out fires essentially. I think a lot of people reflected on feeling like even doing that, like the standard 30-minute follow-up visit that I think a lot of us have, is not always enough to even do that. And so time was like a universal concern. And I know that this isn't mostly academic practices. My sense is that a lot of private practices may even have really shorter, even shorter visits, which wasn't captured in these interviews, but I see as being a future issue when I think about interventions. Other barriers that came up, so I brought up like there's the emotional concerns. Sometimes people are just really worried that someone's upset or someone's not ready to hear it. People alluded to the idea that if you have a longitudinal relationship, like you don't have to build Rome all in one visit. We can sort of do this over a couple visits or bring in someone support person to be there with them. Um, Concerns about sometimes like cognitive impairment, if present, can be a barrier to someone understanding a lot of medical information, or it may feel overwhelming. And at least one participant brought up a prior experience they'd had where they'd been practicing in a certain setting where they felt like sometimes like the health literacy was relatively low in the area they were in. And statistically, if you there is data out there about health literacy in the United States, it tends to be on the low side. Like we're always told to, publish patient materials at a certain reading level, that can be a barrier to effectively sharing information, or it can be more challenging. Or, someone brought up a time when they switched jobs and they sort of therefore kind of inherited or took over care for a lot of patients from someone who left, and felt like whatever that person was doing, like their patients didn't seem to have a great grasp on like what Parkinson's was, or felt like no one had ever really said like this is a progressive disorder. And so they were trying to do all this catch up and that in just disease education, and that was really challenging. So many barriers out there. So third theme, team-based care facilitates anticipatory guidance in PD. Multiple participants, again, mostly in academic settings, alluded to support staff or consultants who have been really helpful in having some of these conversations or helping with some of the planning. So Paul, an academic movement disorder specialist, said, we do have palliative care physicians here that we work with. One's actually neurospecific. And so he does help with some of these additional conversations. And Stephanie also brought up, I find patients really tend to respond well when the nurses talk to them about this. And we have a nurse navigator who sees patients both with movement and neuropalliative, and that's been extremely helpful. Other people brought up like having social work embedded can be really helpful, especially with aspects like legal or financial planning or some of those things, housing considerations that physicians might just like not always feel comfortable with. And there were a few people who worked or had worked before in like a multidisciplinary or interdisciplinary clinic where it was routine to just have, people would see their neurologist, but also see like other team members, like maybe a nurse practitioner or social work or chaplain or other people who could help with some of this and make it really routine and bake it in. And then, having multiple team members doesn't mean like one person has to try to do a million things in one visit, which might be unrealistic. So some people brought that up as like a really positive support in making sure this happens. And then theme 4, this is honestly maybe surprising to me. Neurologists want education to improve anticipatory guidance in PD. I think I was not really sure when I set out doing these interviews, like, do neurologists think this is important? Do they want to be doing this? And I thought the answer was really mostly yes. And I would ask, like, what kind of training would you like to see to help people figure out how to do this? Emily was one neurologist who, as I recall, did not feel very comfortable talking about future disease progression, but said, if I'm going to the Movement Disorder Society or annual or American Academy of Neurology or something, if that was a session, meaning a session on anticipatory guidance or communication, I would actually find myself wanting to join in on that. Just in case anyone isn't familiar, the International Movement Disorder Society and American Academy of Neurology have annual, like very large professional meetings with a lot of continuing medical education. And in recent years, they have had some stuff on serious illness communication, actually. And Donna said, I think it's a skill every neurologist should have to be able to have these conversations and give this guidance. And actually one participant was a neurology residency director in a major academic medical center who said like that she was really working in illness communication and communication skills like to the residency curriculum for just every neurology resident as a basic competency. Some of those residents will see people with Parkinson's, some won't, but that she really felt that it was a basic competency. I don't know. This gives me a lot of hope because I think I was really worried as someone who cares a lot about this that I was going to go like interview a bunch of neurologists and find that my peers maybe don't care or weren't interested. I feel like that was like, okay, good. Like the biggest hurdle isn't going to be a big hurdle because if neurologists weren't interested, like that would be changing culture and interest is hard. But people want this, and I actually had a few people who responded to my recruitment posts online saying like, will you give me education? Like I want intervention. I had to say like, no, it's not that type of study. We're just going to talk. But I did actually share with a few people some resources for how they could find extra training in serious illness communication. So I thought that gave me a lot of hope for the world, actually, just as part of the recruiting experience. So limitations, every study has them. No one does a perfect study. Most neurologists were academic movement disorder specialists. So the barriers that they experience and the resources that they have and alluded to are probably not representative of like most neurologists. And not every person with Parkinson's sees a movement disorder specialist. Not every person with Parkinson's is seen in an academic center. Not everyone even sees a neurologist necessarily. A little bit of a different can of worms, but it is just the reality on the ground. And it was very hard for me. I wasn't able to really recruit anyone in like a community practice, unfortunately. Most neurologists were in their early career, and there may be like a generational gap between like people my age, like I'm pretty junior in my academic rank. There might be a real generational difference between like me and someone who's like on the later end of their career, realistically. Most of the people with Parkinson's and care partners were recruited from the academic movement disorder center that I work in and our surrounding community. So some people were at the private healthcare system, like our other healthcare system in town, but our community has a lot of resources for people with Parkinson's, actually. No one's perfect, but there are like quite a few support groups, including some focused ones. Like there's one for young onset PD, there's one for women with Parkinson's. One quote I shared in this talk was someone referencing like sort of an educational network in town. And so I'm cognizant that when I say like people are reading up and people are going to support groups like this, like I recruited these people mostly from Rochester, New York. If someone in, like a more rural section of America where there can be healthcare deserts and there's just like fewer people and therefore fewer people with Parkinson's, they might be having a different experience. And I didn't really capture their perspective here. So if anyone has great connections to like the Parkinson's community in rural Idaho, like I would love to talk to you because it is really challenging for me in the Northeast at a big center for me to reach those folks. So maybe not a representative sample of like everyone in the US with Parkinson's. And then I think like a perpetual pitfall when you're doing any study about Parkinson's or another like really serious neurologic illness is that the people with Parkinson's and the care partners who responded to my recruitment calls and who ultimately agreed after talking to me to hear some more and ultimately to sign up an interview are people who just might be having overall like less burden or less of a difficult time compared to people who like turn me down to join the study or compared to the broader population. I recognize that realistically, like people are very busy when they're dealing with a chronic illness, or a lot of people are. There's a lot of appointments and physical therapy and all the things. And that there probably is a subset of people who just sort of like didn't answer my call, said they couldn't do it, looked at the information sheet I sent and then were like, no, I don't have an hour to talk to you because the information sheet says this interview could take up to an hour, though it didn't always. And I think that's a real challenge, just like whenever we're doing these types of studies, that people who might be having like the most difficult experiences, who may have really interesting insights into what they wish they'd known about, are just the people who may not have it right now to be in a study, which is like really understandable, but it is something that I think we all struggle with. We might be reaching the people having the least challenging time when we do these. And then, so next step, so I got to wrap up data analysis, finalize these themes and publish them to bring the world, bring the neurology community's attention to them. And then I'm really starting to think about developing an intervention. I think it has to be something that is not reliant on clinic time because everyone is stretched thin, and it came up a lot in interviews, including from patients and care partners sometimes, who even said, like, I come with a bunch of symptoms I want to address in my appointment. I don't always want to zoom out and think about the big picture. And there is a national shortage of neurologists, and there is not a national shortage of people with neurologic concerns, unfortunately. So I don't think the clinic time problem is going to go away anytime soon. And probably shouldn't rely on support staff that are not universally available. Like in my center, I could probably pretty easily find a social worker who'd be like really interested in sitting down and going through like social work needs across the Parkinson spectrum, but people in community practice or solo practice probably don't have that, and so we can't really rely on that. Maybe something that could be delivered at least in part by peers, like a peer navigator or peer mentor. There may be pieces about, prognostication for an individual if someone wants to know about like will the next few years evolve for me? Like maybe that is a piece that would have to come from an individual neurologist. But I think there might be a lot of this that could be done by a peer potentially. This could be stuff that has like written down materials, videos, or other things. But I think we probably like cannot rely for pragmatic reasons on like one-on-one discussion with a physician. And I'm probably not the best person to do like legal planning with someone anyway. And then I'd have to figure out, like, is it a feasible intervention to do? Is it acceptable to the people receiving the intervention, people accepting the intervention? And then it would be a bigger study to test that efficacy. And I'd have to think some more about like what are the important outcomes for people with Parkinson's, for care partners, and for neurologists. Like what kind of efficacy would we want to test? It can be hard to like test an intervention for does it prevent bad outcomes far down the line. That can be really hard to capture. There's even measurements out there for things like preparedness for caregiving, which for care partners might be a really important outcome measure. There are measures of self-efficacy, like how well do people feel prepared to kind of like manage their own condition. There's scales of like illness uncertainty and distress around that, and perceived adequacy of information was a scale I learned about recently that I'm going to look into. So that's another thing where I think we have to do some more thinking about that. Like, what is the most important outcome for patients and care partners, and whoever's doing the intervention, that we would test in a trial, because we'd have to pick something to measure, ideally something that's fairly patient and family centered. I'll pause here. Thank you so much for listening. I'm happy to take questions, comments, ideas you have about any next steps. Like, if happy to hear if any of this like resonated with people, or if you disagree with anything that my study participants said. And if you might be interested in participating in a future study, because I always have like the next one ready to go, or possibly joining like a patient and care partner advisory council for research. My email is here, and the best way for us to connect would be to just email me at this address, and happy to find a time to chat more or talk about like studies that I might do in future if you wanted to participate. So I'll pause here.
Thank you. And actually, before we go into questions to you, I actually have some questions for our audience participants, and we're going to do this via poll. So we want to know, have you had a conversation about future progression with your healthcare provider? And answer, I wish my doctor would talk to me about planning for the future. So we're curious where you guys stand. So we'll give you guys a second. Okay. This was really good data. And I love that you have the perspective of the person with Parkinson's, the care partner, but also the neurologist perspective. That's really helpful to hear them. While we're waiting for people to finish the polls, Dr. Corcoran actually presented at ATMRD, which is our Advanced Therapeutics and Movement-Related Disorders conference that PMD Alliance puts on every year with Georgetown on this topic. And the previous year, we had some others that came in and spoke about the role of this in terms of the larger scope of neuropalliative care. And so going back to that conversation that Dr. Corcoran was just having around preparing and helping healthcare providers, because we do tend to target those in early career, this is an opportunity for them to at least start scratching that surface. Okay, so I think we're close to being done. So right now, our majority are saying that they have not had, so 78%, Dr. Corcoran, are saying they have not had a conversation about future progression with their healthcare provider, and 81% are saying yes, they would like to have a conversation. I wish their doctor would talk to them about it. So
That
I
tracks.
have a question for you.
Mhm.
Sorry, as soon as I get this off my screen and I can see you. What would you recommend to those who haven't had a conversation with their healthcare provider, their doctor, about future planning, if they haven't been asked? How would they maybe feel, especially since that's such a big conversation to approach that?
Yeah, like where to even start.
Yeah.
Yeah, and I will say, like, I'm a neuropalliative physician, so I will sometimes do a full consult just on future planning. But then I have the luxury of like, this is what we're doing today. This was the ask for us, and so I don't necessarily have to do address other issues. I think it is a huge bucket. It is a huge topic, and in some ways a huger topic if you're early in disease, just because sometimes if someone is early on, they have some tremor, not a lot of disability or anything, it's like hard to sometimes know what the trajectory is going to look like. I think it's always helpful if you could maybe start like signaling to your doctor, like, this is something that's on my mind and I'd like to start asking you about it. Coming up with some priorities, if you have some, like if you have a specific concern that you want to talk about early, is a good thing. Because I think I could do like a 3 hour lecture on like Parkinson's progression and planning. That's not necessarily addressing your concerns. And it's also like, time is limited. We have to kind of triage what we're doing. So I think it's helpful if people have a sense of what their concerns are. Like if when I dig in, I commonly get questions like, what should I do about housing? Like Rochester, New York has a lot of these really beautiful, like 3-story Tudor historic homes that people are wondering if they can stay in. And then, I might have questions about like, how are things doing with your walking now? Like, how are you doing with the stairs? Like, have you thought about like moving out, and like, what's the barrier for that? And then we can talk about that. Like, is this really a home where you're going to age in place? And then I'll sometimes talk about like, well, these are some of the things that in my experience are a trigger for people moving out of their original home, especially if it's going to be like really hard to modify, like a lot of these old houses are. And then, see how that resonates and we can have a conversation. If it's like, I don't have a healthcare proxy, I've never done any medical advanced care planning, can we talk about that? It's like helpful for me to know if like that's the biggest priority, and then we can tailor the discussion there. If they are not receptive to having this discussion at all, I think it's very fair to ask, like, who can I talk to? Like, is there a palliative care physician? Like, is there someone else who can help me? If it's like financial legal, like you're wondering about like a financial power of attorney or something, like getting an elder law attorney might be the person to talk to.
I just want to note that Kelly just dropped in the chat a couple of resources from PMD Alliance. One is about planning for the future. The other one is called the Roadmap to Care. If you guys have not seen those were tools that we created, especially for those who may not be going to a comprehensive movement disorders clinic where they have all of the team members available, or available to see a neuropalliative care physician or team, to kind of give you a starting point. So the Roadmap to Care really just kind of talks about each stage of the disease. What are some things that you might see in terms of symptoms? What are some things that you might be doing to address that? And then, maybe even be proactive in addressing issues. And then what are some things that you might be thinking about in terms of the long-term care planning aspects, like when you should talk to a financial planner, and when you should evaluate whether your home is something that you can age in place in. Can it be modified? Do you have funds for that? And what kind of long-term care is acceptable to you, and what does that look like? Because the earlier you have that identified for yourself in those conversations, then the more time you have to be able to put some of those into place. And so that kind of helps you see what that roadmap looks like. And then that planning for the future tool actually helps you understand, like, well, who do you engage to actually even address some of these questions, especially if you don't have a social worker or somebody like a nurse navigator that is skilled and can give you connections to resources. These are general resources that you can get on the internet and a starting point, so it doesn't specifically give you someone local to talk to, but can give you a starting point. So it's really important. And I will say there was a comment that as a care partner, getting good information on what to expect as Parkinson's progresses, understanding that everybody is different, is very difficult, and planning for care and financial impact is frustrating.
Yeah. So this is hard. I gave some people advice. Some of the neurologists I gave advice after the interview is they would be like, some people are like, "How do you do it?" And one thing that's fair, like if this is not like a trial tested intervention, but if I were you and I really wanted to know, some questions you might ask if you wanted to try to pull this out of someone who is like nervous or doesn't know how to talk about it, might be a question like, what are some of the complications that like we might be worried about in later disease or something like that? Like what are the types of issues that come up with Parkinson's disease later in the journey, because they might feel a little more comfortable. Like if I think some physicians take uncertainty as a reason not to say anything, right? It is really hard to know for one person in front of you exactly how's the future going to go. But like we often can talk about a range of possibilities. Some are more likely than others. So, right, like with the housing question, I'll talk about like, well, some people have gait and balance difficulties that make the stairs really hard or make that, and that can make an old home unsafe. There could be like all these other needs, but so you could certainly try to ask about like what are some of the complications that you see come up in later stage disease, things like that. And try to get to them to like put their nickel down or give you some more actionable information. Hope that's helpful, but that's what I would do maybe if I were in your shoes and I had to sort of drag this out of somebody.
And I'm going to say this on the flip side of that, is that we did a survey. I think I shared this with you before we hopped on, about a year ago, on the things that people were not disclosing to their physicians, either because they didn't recognize it as a problem with Parkinson's, or they had other reasons that they weren't. And I will share that they were, a lot of them, around fear and embarrassment, but these were significant symptoms that many of which could be treated, and or addressed, if they had the conversation. So if you have things that you're concerned about, or you want more information on, or how that relates to disease progression and what to anticipate, part of that is also being comfortable with your physician to actually bring up those issues. And so I don't know if you have, Dr. Corcoran, like any encouragement on kind of reducing stigma or fear around sharing things that might be embarrassing or might cause anxiety because they're afraid what the doctor might tell them. How would you address that or support that?
Yeah. So it's kind of a stereotype, but we hear it all, right? I have like entire. I'm not sure. I'd be interested to know like what the most. I should have asked you before we started. Like, what were like some of the most common issues that people didn't want to report? But if it's like embarrassing, like I've had certainly had people blush talking about like constipation, which is like a nearly universal problem with Parkinson's disease. Like I ask everybody because it's nearly universal. I'm like, hey, if it gets bad enough, you could wind up in the ER. So I ask everybody about it. It's also not always that hard to treat, honestly, if someone just asks about it and does something about it. So I don't know. We hear it all. Like I've heard about people's concerns about like sexual function and like satisfaction with sexuality. I've heard about constipation. This is a little bit of a hot button issue, but just to name it, like there's data out there about, caregivers experiencing violence in the caregiving role. Like I do ask about it, so but we hear about this all the time. So they've probably heard it before. We hear, kind of more touchy stuff than you might think in neurology. And also you can just signpost with like, this is hard for me to talk about, or this is a little embarrassing. Because when I hear that, I will really try to make every effort to like just have all my listening ears on, because someone kind of signposted that this was tough. So it's okay to just acknowledge it. Like, I'm feeling embarrassed bringing this up, but bring up whatever your concern is. The other sort of like, touchy subject potentially, but sometimes, especially if someone with Parkinson's has some cognitive impairment, or like,
Mhm.
some of the psychiatric complications of Parkinson's, sometimes care partners or families want to tell us things not in the room in front of them. That does happen. A phone call to the office, or if you have a My Chart or like patient portal, whatever your patient portal setup is, I pretty routinely get patient portal messages in advance of visits where a care partner or a family member wants to let me know something, and they don't want to say it in front of the person with Parkinson's, and they'll let me try to bring it up. So like driving would be one really hot button topic that comes up a lot. Like they're concerned. They don't want to be the bad guy. I'm not going home after the end of the visit. Like I can be the bad guy, right? If I totally tank a clinical relationship saying someone can't drive anymore, I have transferred care. I have had situations where I was the bad guy and then transferred care to someone in my group if that person didn't want to see me anymore. Like I can be the messenger. Sometimes the messenger's getting shot. Like I can be shot. The family doesn't have to be shot.
Well, we're just about out of time, and I want to thank you for having this conversation. It's an important one, bringing up an important subject, and for the work that you're doing, trying to better understand um, people's perspective and our treating physicians' perspective.
All right. Thank you so much for having me.
And we have a tradition. This is the first time you've been on a PMD Alliance program live stream. You've spoken for us at ATMRD, but with our community, this is the first time. And first of all, I want to thank you for that and becoming a part of our family. But because we have a great group of people and they come from all over the country, but they're muted, so they can't clap. It's a little weird online to clap anyway, but we do what's called the wave of gratitude. So we want to thank you so much. So I invite everybody, turn your cameras on, get Dr. Corcoran that wave of gratitude. Thank her so much for today.
All right. Well, thank you so much. That's a lovely tradition.
Thank you. And I hope everybody grabbed those resources off there. You can save your chat and get those documents if they would be helpful to you. And if not, you can always reach out to us and we'll make sure you get those. And I hope everyone has a great day.
Thank you so much. Have a good one.